the desktop
How
folder.
about, how about this?
Yeah, there you go. Perfect.
All right, we're good?
We're good. We're golden.
Okay, excellent. Great. Thanks everyone for joining today. I'm going to try to make a somewhat boring topic more interesting. So we're going to talk a little bit about the epidemiology, about nephrolithiasis, review the AUA guidelines on surgical management of kidney stones, including a pre-op evaluation, treatment of ureteral and renal stones, special cases, and review the metabolic evaluation, and then do some practice questions. So this is basically taken from the AUA and Endourology Society guidelines. If you read all the guidelines, it can be pretty dull, so I'll try to make it a little bit more exciting. And what I found very interesting when I looked at the different topics in the guidelines, much of what you see in the guidelines may be different than what you see or actually do in practice or see in some of the attendings that you work with in practice. So we'll talk a little about the epidemiology, the natural history, of course, the peak incidence being in the age between the 20s and 50s. There's a 3-to-1 preponderance for male dominance for stone formation. There's a threefold increase when there's a family history, and there's an increased risk with body habitus, so increased weight. There is a higher incidence of stones in whites compared to blacks. And this is a significant healthcare issue. When you look at the number of cases per year, it's a 0.8% incidence, 2.9 million cases per year, 7 to 10 out of 1,000 hospital admissions for stone disease. And in 1994, 12% of men and 5% of women would experience a calculus by the age of 70. And by 2012, that increased to 19% of men and almost 10% of women who would experience a stone at some point in their lifetime by the time they were 7 years old. Now, when you form a stone, the recurrence within 5 to 10 years is about 10 to 15% in the first year, 50 to 60% by year 5, and 70 to 80% by year 10. So this is a significant problem. And for this reason, metabolic evaluation to prevent stones is as important as surgical management of stone disease. So what are the environmental risk factors? If you look at the a map of the United States, you can see by 2095, more and more of the country is going to be hit with these heat waves, and the stone belt, which is typically right here in the southeast, stretching all the way to the southwest, is going to gradually increase up to even some of the mid-Atlantic states. And look at where we are right here, New York and New Jersey. Hot climate, formerly known as the stone belt, which keeps getting wider and wider. There's an increased prevalence during the summer. Of course, hard water and increased mineral content has been associated with stone formation. Diet, high salt intake, and occupation, so sedentary occupations, or occupations that predispose people to stones when they're working in hot environments and not hydrating enough. Risk factors for recurrence include a younger age at the initial presentation, a family history of stones, underlying medical conditions, as well as recurrent urinary tract infections. So starting with imaging, from when I was in residency, an IVP and a tomogram were sort of the standard imaging studies that we would obtain for kidney stones. That tells you, sort of dates me and tells you about where things have progressed to. Now the non-contrast CT is the standard. And when you look at the guidelines, number one for surgical management is clinicians should obtain a non-contrast CT scan on patients prior to performing PCNL. Clinicians may obtain a non-contrast CT to help a best candidate for shockwave lithotripsy versus ureteroscopy. And clinicians may obtain further imaging studies, such as a functional imaging study, if there's clinical significant loss of renal function or suspected involvement in one or both kidneys. Guideline number 4, clinicians are required to obtain a urinalysis prior to intervention. Urine culture is not always required, although many urologists will always obtain a urine culture, but a urinalysis is mandatory. If there's a question of an infection, a urine culture should be obtained. Clinicians should also obtain a CBC and a platelet count in patients only if there's a significant risk of hemorrhage, or for patients with symptoms suggesting anemia, thrombocytopenia, any other blood-borne disorder or infection. Furthermore, serum electrolytes should be obtained if there is a suspicion of reduced renal function. Guideline number 6, in patients with complex stones or anatomy, clinicians may obtain additional contrast imaging if further definition of the collecting system and the ureteral anatomy is needed. So again, in complex situations, whether it's a stone or the anatomy itself, additional imaging such as a CT urogram or an MR urogram may be obtained. In terms of treating ureteral stones in adults, patients with uncomplicated ureteral stones less than or equal to 10 millimeters should be offered observation. This is uncomplicated, asymptomatic stones. Those with distal stones of similar size should be offered medical expulsive therapy with alpha blockers. All right, this is very different than what often is practiced, as we oftentimes will say, oh, there's a ureteral stone that's 9 millimeters, we should go and intervene. If the patient is asymptomatic and it's uncomplicated, observation should be offered and shared decision-making should be performed. Clinicians should offer re-imaging to these patients prior to surgery if passage of stones is suspected or if the stone movement will change management. So we should focus on the region of interest. If it's a distal ureteral stone, you can obtain a CT scan of the pelvis. If it's a proximal ureteral stone, you can obtain a CT scan of the abdomen. Or if there's suspicion that the stone has progressed, you may obtain a CT scan of the abdomen and pelvis. Additional imaging studies can also be ultrasound. Ultrasonography is excellent for looking at proximal ureteral stones, renal stones, and stones in the distal ureter. Can also look for ureteral jets. Number 9, if observation with or without medical expulsive therapy is not successful after 4 to 6 weeks, definitive stone treatment should be offered. Why is that? Silent obstruction beyond 4 to 6 weeks can cause irreversible damage to the kidney, so it's very important to follow up with these patients. Number 10, clinicians should inform patients that shockwave lithotripsy is the procedure with the least morbidity and lowest complication rate. Again, least morbidity and lowest complication rate. Although they should also inform patients that ureteroscopy, although it's more invasive and a higher complication rate, has a greater stone-free rate in a single procedure. Guideline number 11, in patients with mid or distal ureteral stones who require intervention, who are not candidates or who failed medical expulsive therapy, clinicians should recommend ureteroscopy as a first-line therapy. Again, mid-ureteral or distal ureteral stones who require intervention, ureteroscopy as a first-line therapy. For patients who decline ureteroscopy for one reason or another, clinicians may offer shockwave lithotripsy. Now, number 12, ureteroscopy is recommended for patients with suspected cystine or uric acid ureteral stones. I'm going to emphasize that. It's recommended to perform ureteroscopy for suspected cystine or uric acid ureteral stones. The reason why is cystine stones are hard stones. They are not oftentimes amenable to shockwave lithotripsy, and uric acid stones oftentimes cannot be seen which are on shockwave lithotripsy unless you're using ultrasound rather than fluoroscopy. Number 13, routine stenting should not be performed in patients undergoing shockwave lithotripsy. That's, I think, goes without saying. Number 14, following ureteroscopy, you may omit ureteral stenting in patients meeting all of the following criteria. And again, all is emphasized because patients must have no suspected ureteral injury during ureteroscopy. There should be no evidence of strictures or other anatomical impediments to stone fragment clearance. They should have a normal contralateral kidney. They should have no renal functional impairment, and those where a secondary ureteroscopy procedure is not planned. So again, ureteral stenting can be omitted in patients. Placement of a ureteral stent prior to ureteroscopy should not be performed routinely. Reason for this being, number 1, it causes pain. Number 2, it doesn't improve the stone clearance rate. And number 3, it can also prolong hospitalization or actually, I'm sorry, I take that back, return to work activities. Number 16, clinicians may offer alpha blockers and antimuscarinic therapy to reduce stent discomfort. So this is a good, it's a moderate recommendation, grade B, but these medications can help alleviate some of the stent discomfort and allow patients to return to normal activity or close to normal activity with the stent in place. 17, in patients who fail or are unlikely to have successful results with shockwave lithotripsy and/or ureteroscopy, clinicians may offer PCNL, laparoscopic, open, or robotic stone removal. And number 19, for ureteral stones, clinicians should not utilize electrohydraulic lithotripsy as a first-line modality for intra-ureteral lithotripsy. I don't think many centers are still doing this. When I was in residency at the VA, we did not have a holmium laser, so we used EHL for ureteral stones as well as for renal stones. 20, in patients with obstructing ureteral stones and suspected infection, clinicians must urgently drain the collecting system with a stent or nephrostomy tube and delay, I repeat, and delay stone treatment. Okay, suspected infection, drainage is key. Emergent drainage, patient with SIRS or sepsis and ureteral stones should be immediately drained. If you suspect a UTI in the setting of ureteral obstruction, you may see the following: a temperature greater than 100, tachycardia, hypotension, leukocytosis, pyuria, or a patient with bilateral obstruction or an obstructed solitary kidney. Emergent drainage is needed without exception. Decompressing the system is important. What about a PCN versus a stent? Urgent drainage with either a PCN or a stent is indicated in the setting of obstruction with signs of infection. We tend to favor a PCN if the patient's too unstable for a general anesthetic, if they have a large impacted stone where we believe that a stent may not be feasible or may injure the ureter by trying to pass a guide wire, or an early pregnancy where you want to avoid fluoroscopy and anesthesia. We also tend to favor a stent, however, if patients are clinically stable on anticoagulation, or if there's difficulty with interventional radiology approach due to lack of hydronephrosis. Oftentimes we may be told by our interventional radiologist, well, there's no hydro, it might be difficult, the patient's body habitus, why don't you go and put a stent in that setting? So these are indications where a stent may be more viable option than a PCN. So ureteral stone summary. For ureteroscopy, it's preferred for mid and distal ureteral stones, preferred for cysteine and uric acid stones. It's a higher single procedure stone-free rate, but also higher morbidity. Shockwave lithotripsy has a lower morbidity and complication rate, but also a lower stone-free rate than ureteroscopy. We should not routinely stent for shockwave lithotripsy either. All right, let's move on to renal stones in adults. Who needs surgery? Well, certainly symptomatic patients that have pain, infection related to stones, including struvite stones, an obstructing stone at the UPJ, or patients who have career or lifestyle concerns, for example, a pilot or a surgeon. Worst thing, my worst nightmare is operating, doing a minimally invasive surgical case, whether it's robotic surgery or ureteroscopy, and having a stone attack. Just imagine what would happen. Thank goodness I have good residents and fellows to help me out. 21, in symptomatic patients with a total non-lower pole renal stone burden less than or equal to 2 centimeters or 20 millimeters, clinicians may offer shockwave lithotripsy or ureteroscopy. Remember, non-lower pole renal stone burden, okay? Reason for that being lower pole stone burden is going to probably stay there unless you really use a basket ureteroscopically to remove all the fragments. But if you do shockwave lithotripsy, you're likely to have fragments that are eventually going to grow. In symptomatic patients with a total renal stone burden greater than 20 millimeters or 2 centimeters, clinicians should offer PCNL as a first-line therapy. And in patients with a total renal stone burden greater than 2 centimeters, clinicians should not offer shockwave lithotripsy as a first-line therapy, which is to say that if PCNL is not offered or is offered as a first-line therapy and a patient elects not to undergo PCNL, ureteroscopy still is an option, but shockwave lithotripsy should not be offered in this setting. 27, why did we move from 25 to 27? Because the other recommendations are in other parts of this lecture. 27, clinicians may perform nephrectomy when the involved kidney has negligible function. What is negligible function? Well, I typically get concerned when we're dealing with under 20% function. Now, if there's a normal contralateral kidney, 18, 19% function, to me is significant. Definitely under 15% function. But again, this is shared decision-making. If there's ever a concern, get a nephrologist involved to see if it's worth salvaging a kidney with under 20% renal function. Number 28, for patients with symptomatic flank pain and non-obstructing calyceal stones without another obvious etiology of pain. Again, symptomatic flank pain, non-obstructing calyceal stones without another obvious etiology of the pain, clinicians may offer stone treatment with the suspicion that the stone may be intermittently causing that patient's pain. 29, for patients with asymptomatic non-obstructive calyceal stones, clinicians may offer active surveillance. So asymptomatic non-obstructing stones, active surveillance is completely acceptable. Number 30, clinicians should offer shockwave lithotripsy or ureteroscopy to patients with symptomatic less than 10 millimeter lower pole renal stones. Now, we're talking about lower pole stones that are 1 centimeter or less. You can offer shockwave lithotripsy or ureteroscopy with nearly equal treatment rates and clearance rates. Clinicians, however, should not offer shockwave lithotripsy as a first-line therapy to patients with greater than 10 millimeter lower pole stones. So ureteroscopy can be offered, percutaneous nephrolithiasis can be offered, but shockwave lithotripsy should not be offered once that stone gets to be above 1 centimeter in diameter in the lower pole. 32, clinicians should inform patients with lower pole stones greater than 1 centimeter in size that PCNL has a higher stone-free rate but greater morbidity. In patients undergoing complicated PCNL who are presumed stone-free, placement of a nephrostomy tube is optional. Tubeless PCNL is gaining more and more popularity, especially with the mini-perc technique. Number 34, flexible nephroscopy should be a routine part of standard PCNL. And what that means is once you feel like the stone is cleared, take a flexible nephroscope, advance it into the different calyces and maybe even into the UPJ to make sure that the stones really are cleared so that you know that you don't have to do a second look procedure or obtain a CT scan afterwards, as we traditionally used to do, to see if there's residual stone burden before sending a patient home or removing their PCN tubes. 35, clinicians must use normal saline irrigation for PCNL and ureteroscopy. Why? Because oftentimes the irrigation will either extravasate during the case of the PCNL, even though it's in the retroperitoneum, or if a perforation or forniceal rupture occurs during ureteroscopy, normal saline is the irrigant that you want to be absorbed by the body and not result in electrolyte abnormalities. 39, in patients not considered candidates for PCNL, clinicians may offer a stage ureteroscopy. So for a variety of reasons, and even sometimes patient preference, they will elect to not undergo PCNL, in which case a stage ureteroscopy can be performed in ureteroscopists who have expertise in performing these procedures for large stone burdens. Patience is key in these scenarios. 40, clinicians may prescribe alpha blockers to facilitate passage of stone fragments following shockwave lithotripsy. 43, shockwave lithotripsy should not be used in the patient with anatomic or functional obstruction. Why is that the case? Well, breaking up the stones or dusting the stones, if the fragments or the stone debris does not pass, then all you're going to end up having is a cluster of stones and increased growth over the long term. In patients with symptomatic calyceal diverticular stones, endoscopic therapy, so ureteroscopic, percutaneous, laparoscopic, or robotic therapy is preferentially utilized. Why? Because in order to obtain access to the calyceal diverticulum, you may be able to access it ureteroscopically by dilating the infundibulum. Percutaneously, you can perc directly into the calyceal diverticulum, and laparoscopic or robotic techniques also to perform a calyceal diverticulectomy, remove the stone burden, and actually tie off the calyx and stuff the calyx with either fat or cauterize the lining or put flow seal or gel foam in so that the calyceal diverticulum will not recur. Number 45, staghorn stones should be removed if attendant comorbidities do not preclude treatment. So a patient with an asymptomatic staghorn stone should be treated. All right, looking at lower pole stones, I really want to just focus on this one area. Less than 1 centimeter stone, symptomatic, shockwave lithotripsy or ureteroscopy are both options. If the patient has more favorable anatomy, so not a steep infundibulopelvic angle, shockwave lithotripsy may be the choice for the patient. If they have unfavorable lower pole anatomy, so a sharp infundibulopelvic angle, or the skin to stone distance is greater than 10 centimeters, or the Hounsfield units are higher, ureteroscopy is a better option because shockwave lithotripsy is less likely to treat the stones due to the distance between the stone and the skin, as well as the higher density stones. Moving on to pediatrics and pregnancy. Treating pediatric stones is very similar guidelines to adults. However, the same indications for treatment and identical management is for ureteral stones. Children need a metabolic evaluation. There is a reason why children are forming stones, and all children should get a 24-hour urine as well as blood work. We must carefully look at the anatomical considerations that could limit the approach. For example, if a child has a ureteroscopic or a UPJ obstruction, these could be indications for why someone is forming stones. Women, or I should say girls, who also have reflux may develop infections, and they can also develop infection stones. Children also may be diagnosed with cystinuria at a very young age. In terms of imaging, it's very important. If you're obtaining a CT scan, you should obtain a low-dose CT scan, but a CT scan should be performed prior to percutaneous nephrolithotomy. Ultrasound can be obtained for follow-up as you want to limit the radiation dose to children. Number 46, in treating pediatric patients with uncomplicated ureteral stones less than or equal to 10 millimeters, clinicians should initially offer observation with or without medical explosive therapy. So these are uncomplicated asymptomatic ureteral stones. We should offer ureteroscopy or shockwave lithotripsy for pediatric patients with ureteral stones who are unlikely to pass the stones or who have failed a trial of observation and or medical explosive therapy, also based on the patient's specific anatomy and the body habitus. So again, ureteroscopy or shockwave lithotripsy for patients who have failed observation or medical explosive therapy. Number 48, obtaining a low dose, and I emphasize a low-dose CT scan on pediatric patients prior to performing PCNL is mandatory. For ureteral stones, we should not routinely place a stent prior to ureteroscopy in children, similar to adults. Now, in terms of the size, in pediatric patients with a total stone burden less than 20 millimeters or 2 centimeters, clinicians may offer shockwave lithotripsy or ureteroscopy as a first-line therapy. In pediatric patients with a total stone burden greater than 20 millimeters, both PCNL and shockwave lithotripsy are acceptable options. If shockwave lithotripsy is utilized, clinicians should place an internalized ureteral stent or nephrostomy tube due to the extensive stone burden and to prevent Steinstrasse and silent obstruction. In pediatric patients, except in cases of coexisting anatomic abnormalities, clinicians should not routinely perform open, laparoscopic, or robotic surgery for upper tract stones in the absence of any, as I said, anatomic abnormalities. For example, UPJ obstruction. In the setting of a UPJ obstruction and a renal pelvis stone, pyeloplasty via laparoscopic, robotic, or open approach, depending on the surgeon's choice, may be appropriate. Number 53, in pediatric patients with asymptomatic and non-obstructing stones, clinicians may utilize active surveillance with periodic ultrasonography. Again, these are stones in the kidney in patients that are asymptomatic. So in terms of treating pediatric stones, again, under 2 centimeters, shockwave lithotripsy or ureteroscopy, greater than 2 centimeters, PCNL or shockwave lithotripsy, but shockwave lithotripsy with postoperative stent placement. In pregnancy, we should avoid radiation when possible. Ultrasound and MRI are both safe. However, CT scans below radiation exposure limits may be offered to the patient if it's necessary to make a surgical decision, if it's unclear whether the patient does have a stone or not. In pregnant patients with ureteral stones that are well-controlled symptoms, clinicians should offer observation as a first-line therapy. However, with patients with ureteral stones, clinicians may offer ureteroscopy who fail a trial of observation. A stent and nephrostomy tube are also alternative treatments, but these require frequent changes, usually every 4 to 6 weeks, as there are higher risk for encrustation. However, with newer stents that are becoming available, this may obviate the need for frequent stent exchanges. Ureteroscopy is becoming more common in the setting of pregnancy. Shockwave lithotripsy and PCNL are contraindicated, and the safest time for anesthesia is the second trimester. We should use as little fluoroscopy as safe. We should shield the fetus, and there's no difference in complications. We should make sure to send a urine culture because pyuria is often common in pregnancy. Now, for all patients with renal or ureteral stones, when residual fragments are present, clinicians should offer patients endoscopic procedures to render the patient stone-free, especially if infection stones are suspected. Again, this is for residual fragments. 24, stone material should be sent for analysis. That should always be the case when it's obtained. Open lap and robotic surgery should not be offered as first-line therapy to most patients with stones. The exception is patients that have anatomic abnormalities with large complex stones or those requiring concomitant reconstruction at the time. Antimicrobial prophylaxis should be administered prior to stone intervention and is based primarily on prior urine culture results, the local antibiogram of an institution, and consultation with the current best practice policy statement on urologic surgery antibiotic prophylaxis. Clinicians should abort stone removal procedures, especially and establish appropriate drainage, continue antibiotic therapy, and obtain a urine culture if purulent urine is encountered during endoscopic intervention. So you put a guide wire up. If you see purulent discharge, you should not proceed with that procedure. You should go for drainage at that point. If you're already doing it endoscopically, a stent is usually the right option. If not, a percutaneous nephrostomy tube is also a good option. Number 41, if shockwave lithotripsy fails, clinicians should offer endoscopic therapy as the next treatment option. So an old motto at an institution that I know about would be that if shockwave lithotripsy fails, shock again. Well, that is not the right guideline recommendation. If shockwave lithotripsy fails once, clinicians should offer endoscopic therapy because it is unlikely to be successful a second time with shockwave lithotripsy. Clinicians should use ureteroscopy as a first-line therapy in most patients who require stone intervention in the setting of uncorrecting bleeding disorders or who require continuous anticoagulation or antiplatelet therapy. I have no issues with performing ureteroscopy when someone's fully anticoagulated. If you get into any bleeding during the procedure, you can always abort, place a stent, and come back at a later time. Surgical modalities, ureteroscopy, dusting versus fragmenting. There's little evidence that one approach is better than the other. I think we're moving more to dusting these days with advances in laser therapy. I think there's a shorter procedure time, less basketing involved, and lower risk of ureteral damage. When you have low power, high frequency settings, you can touch the mucosa and cause significantly less damage than when the power is much higher. The dusting settings that I prefer are usually 0.2 and 50 with a 100-watt laser, or 0.2 to 0.3 and 80 with the newer high power lasers. Moses technology is one such therapy which uses pulse modulation. The outcomes result in higher ablation of the stone. There is reduction in retropulsion, and there's reduction in procedure time. When we consider shockwave lithotripsy, again, we're looking at the infundibulopelvic angle, as I mentioned earlier. There are definitely lower success rates for lower calyceal stones, and when the skin to stone distance is greater than 10 centimeters. Stone size, best for treatment for stones under 10 millimeter. 10 to 20 millimeter is only favorable. The composition is a softer stone and not within the lower pole, and definitely not for stones over 20 millimeters in size. And for obesity, shockwave lithotripsy may not be optimal for BMI greater than 30 or a SSD greater than 10 centimeters, and certainly contraindicated in pregnancy. Size does matter. Total non-lower pole stone burden under 20 millimeters, shockwave lithotripsy or ureteroscopy are options. When the stone burden is greater than 20 millimeters, PCNL should be the first choice. When we're under 10 millimeters for a lower pole stone, shockwave lithotripsy or ureteroscopy are reasonable. When it's greater than 10 millimeters, we should not offer shockwave lithotripsy. We should offer ureteroscopy or percutaneous nephrolithotomy. And PCNL has a higher stone-free rate, but greater morbidity compared to ureteroscopy, especially when the stones are above 10 millimeters in size. PCNL, we talked about this, again, stones of composition that are relatively shockwave resistant, large stone burdens, lower post stones greater than or equal to 1 centimeters, and abnormal renal anatomy that may preclude ureteroscopy or impair fragment passage after shockwave lithotripsy. These are indications for PCNL. Talked about mini PCNL. Basically, all you need to know about this is that we're miniaturizing tracts. We can perform the same type of procedure with less morbidity and more inclination to do the procedure tubeless. And laparoscopic and robotic surgery, anatrophic nephrolithotomy, pyelolithotomy, and ureteral lithotomy are all options in various settings, but should not be first-line therapies in most instances. In terms of follow-up, there's always a risk of silent hydronephrosis. So I recommend, and so do the guidelines recommend, obtaining a renal ultrasound and a KUB postoperatively, typically at about 4 weeks. I'll typically give the individual a prescription for an ultrasound to look for ureteral jets and no hydronephrosis. In the setting of a PCNL, consider suppressive antibiotics for infection stones and a KUB plus ultrasound in 6 to 8 weeks versus immediate post-op CT to perform if someone may do a second look procedure. We should offer repeat surgery if stone fragments are detected, especially infection stones. Obtain a stone analysis when possible, and medical evaluation or management per guidelines. All right, let's move on to some questions before hopefully we'll have some time to go over metabolic evaluation as well. So question number 1, stent placement after uncomplicated ureteroscopic stone extraction for a 5 millimeter distal ureteral calculus. So should a stent be placed? It's indicated if shockwave lithotripsy, or sorry, intracorporeal lithotripsy is performed, improves stone-free rate, increases post-procedure pain, is indicated if balloon dilation was performed, or reduces the likelihood of ureteral strictures. So stent placement after uncomplicated ureteral stone extraction. If you remember what I said earlier, it increases post-procedural pain. So stent placement is not always required after uncomplicated ureteroscopic stone extraction for stones under 10 millimeters in size. Stents do not impact stone-free rate, but do increase post-procedural pain, symptoms, and narcotic use. Number 2, the primary advantage of ultrasound for shockwave stone localization is A, capability for continuous real-time monitoring, B, short learning curve, C, multifunctional use for diagnosis of endourological treatment, D, ability to identify ureteral calculi, and E, efficacy in clinical situations with multiple calculi. Well, I think D and E are definitely wrong in this scenario. I think B, in terms of short learning curve, unless you've taken an ultrasound course, probably not. So we're left with A and C. The answer is A, capability for continuous real-time monitoring. The advantages of ultrasound for stone localization are low purchase cost and maintenance, no X-ray exposure, and the possibility of continuous real-time monitoring, as well as location of radiolucent renal or proximal ureteral calculi. Question number 3, a 42-year-old man has persistent ileus and fever after left PCNL. Nephrostogram demonstrates that the nephrostomy tube has traversed the colon in its passage into the renal pelvis. The next step is IV antibiotics, and this question has been showing up for over 2 decades. So while it's rare, if the colon is posterior enough or lateral enough, it's possible to place a access tract through the colon. So in this scenario, what's the answer? Colostomy, that's open colostomy and drainage of the area. Colonic repair, so open surgery and drainage of the area. Removal of the nephrostomy tube immediately. Withdrawing the nephrostomy tube into the colon and placing a ureteral stent. Or replacing the nephrostomy tube in a more posterior position. Well, I can tell you to start, surgery is not the right answer. Taking the nephrostomy tube out, you may think that might be your first instinct. Oh my goodness, the nephrostomy tube is through the colon, let's just pull it out. But that's not the right answer either. The answer is actually withdrawing the nephrostomy tube into the colon. So if the nephrostomy tube is through the colon, you want to bring it back into the colon, whether it's a Malacot nephrostomy tube or a balloon type Foley catheter, withdraw it into the colon, place your ureteral stent, continue the antibiotics, and then gradually advance Once the patient's stable, advance the nephrostomy tube out. Of course, if you have a balloon inflated, deflate the balloon and gradually bring it out. Treat it like a drain until the colonic injury seals. So separate drainage of the colon and urinary system should resolve the problem. Question number 4, a 36-year-old woman with a horseshoe kidney has a symptomatic 1.8 centimeter left lower calyceal stone. The next step is horseshoe kidney, left 1.8 centimeter stone, shockwave lithotripsy, open nephrolithotomy, ureteroscopic stone extraction, ureteral stent and shockwave lithotripsy, percutaneous nephrolithotomy. All right, most people are probably not going to say A. No one's really doing open nephrolithotomies to any extent these days, so it's not going to be B. Ureteroscopic stone extraction, definitely an option. A stent and shockwave lithotripsy, again, not a good option for horseshoe kidney. This is abnormal anatomy, which may preclude drainage. Percutaneous nephrolithotomy. So we're left with C and E. Let's see what the answer is. For those of you that said PCNL, the answer is correct. PCNL can safely be performed through a superior and posterior calyceal puncture in patients with horseshoe kidneys. Number 5, a 42-year-old man has severe right flank pain and microscopic hematuria. CT scan demonstrates a 5 millimeter distal ureteral calculus and forniceal extravasation. Following adequate pain control, the next step is shockwave lithotripsy, ureteral stent, ureteroscopy, observation, or PCNL. Now, this is an interesting question here because what we often will do is actually not the right answer in this scenario. And I see many people getting this question wrong. They think the answer is ureteral stent because you think, oh my goodness, there's an obstruction, there's a forniceal rupture, and there's extravasation. We need to drain the system so we can drain that fluid that's retroperitoneal. The correct answer is actually observation. The reason being that intervention is typically not necessary when the urine is infected, except when the urine is infected. If there's obstruction or the pain is uncontrollable, then you would need to intervene, or if there's in a setting of infection. If the stone is large and also not likely to pass, intervention may be necessary. Otherwise, if it's a small stone, the stone will oftentimes pass on its own without intervention as long as the patient's asymptomatic. Question number 6, the stone composition most resistant to fragmentation with shockwave lithotripsy is, this should be an easy one, calcium oxalate monohydrate, calcium oxalate dihydrate, hydroxyapatite, uric acid, and struvite. Looks like someone already outlined the answer right there. Calcium oxalate monohydrate is the correct answer. Calcium oxalate monohydrate, brushite, and cystine stones are the hardest of the stones that we encounter and are least fragile and resistant to shockwave lithotripsy. Number 7, the most significant difference between ureteroscopy and shockwave lithotripsy for a 1 centimeter lower pole kidney stone is the stone-free rate, need for stenting, length of stay, postoperative complication rate, and return to work. So ureteroscopy and shockwave lithotripsy for a 1 centimeter lower pole kidney stone. We said stone-free rate is about the same. Need for stenting, you shouldn't really need to stent when the stone's 1 centimeter or less in shockwave lithotripsy. Length of stay, these are typically outpatient procedures. Postoperative complication rate, not necessarily higher one than the other. The answer is actually return to work. When you perform ureteroscopy in this setting, if you place a stent, return to work is 8.5 days for ureteroscopy compared to 3.3 days following shockwave lithotripsy. And this was just noted in one study. Question number 8. The irrigating solution that should be used for diagnostic percutaneous nephroscopy or ureteroscopy is glycine? Not true. Sterile water? Maybe. 3% glycine? Definitely not. 0.9% sodium chloride? or 0.15% sodium chloride? Well, I don't ever see the use of 0.15% sodium chloride. So it's either sterile water or 0.9% sodium chloride, and the answer is D. All right, we mentioned that earlier. Normal saline is both isotonic and non-conductive, whereas the other listed fluids do not share these properties. Question number 9, a 53-year-old woman has recurrent Proteus infections. CT scan shows a right renal staghorn calculus. Urine culture is negative. The next step is stage shockwave lithotripsy with stent, ureteroscopy with laser lithotripsy, PCNL, acetohydroxamic acid, percutaneous nephrostomy with hemosiderin irrigation. Let's see. Well, it's not going to be D or E. Stage shockwave lithotripsy is definitely not the right answer because we're not even telling how big the staghorn calculus is. And ureteroscopy, again, we don't know the size of that stone. It could be 5 centimeters from craniocaudal distance. So PCNL should be the answer, and it is. The AUA guidelines strongly recommends PCNL as a first-line therapy for management of staghorn calculi in patients that are asymptomatic. Question number 10, a decrease in renal injury with shockwave lithotripsy can be accomplished by starting at a low energy setting and pausing for 3 to 4 minutes before increasing the energy setting, increasing the shockwave firing rate, and starting at a low energy setting, starting at a low shockwave firing rate and pausing for 3 to 4 minutes before increasing the shockwave firing rate. Okay, so let's think about this. Let's look at C, increasing the shockwave firing rate. So you're firing more shockwaves. Is that going to increase or decrease renal injury? It probably would increase renal injury. What about D? If we increase the shockwave firing rate and start at a low energy setting, again, if we're increasing the shockwave firing rate, we're more likely to cause more damage. What about E? Starting at a slow firing rate, pausing for 3 to 4 minutes before increasing the shockwave firing rate. Okay, that sounds like an option. Starting at a low energy setting, that's A. It's an option. Starting at a low energy setting and pausing for 3 to 4 minutes before increasing the energy setting. All right, who thinks it's A? Who thinks it's B? And who thinks it's E? The right answer is B. Starting at a low energy setting and actually pausing for 3 to 4 minutes before increasing the energy setting has shown to minimize renal injury. All right, we have another 14 minutes. Let's move on to medical management. What is medical management? It involves the initiation of dietary measures or in some cases medications to reduce the risk of stone recurrence. This is for recurrent stone formers, high-risk first-time stone formers, or interested first-time stone formers who don't ever want to experience a stone again. The basis for recommendations could be empiric or it could be based on stone composition and underlying pathophysiologic risk factors. The evaluation, so at the initial visit, if someone has their first stone and they're without risk, they can have a simplified metabolic evaluation. If it's their first stone and they're at risk, maybe they have a family history or they have some other abnormality, they would require an extensive evaluation. If they have recurrent stones, they should require an extensive evaluation. The difference between a simplified and extensive evaluation is the number of laboratory tests that you order, as well as doing 1 versus 2 24-hour urine collections. So a low-risk patient is a first-time stone former without a family history, with no intestinal disease, gout, recurrent infections, nephrocalcinosis, diabetes, or obesity. Compare that to the high-risk patient who is a recurrent stone former, any child or adolescent, anyone with a solitary kidney, or the family history, malabsorptive intestinal disease, gout, recurrent UTIs, nephrocalcinosis, diabetes mellitus, or obesity. So for low-risk patients, only screening is advised, and for high-risk patients, a metabolic evaluation is required. So who needs a metabolic evaluation? Uric acid stone formers. Only 10% of stone formers are uric acid formers, but they need a metabolic evaluation. Cysteine stone formers, infection stone formers, and calcium stone formers that are recurrent or multiple stone formers. So either you have a recurrent stone, you've had a stone in the past, you've had more stones subsequently, or At initial presentation, someone may have more than one stone in one kidney, or they may have stones in both kidneys. They need a metabolic evaluation. Stones that have been difficult to treat, they need a metabolic evaluation. Children or solitary kidneys, nephrocalcinosis, bone disease, and GI diseases who form stones. 24-hour urine collection looks for a number of different variables. We look at volume, we look at pH, supersaturation of calcium oxalate, sodium citrate, phosphorus, magnesium. And this is what it looks like. And I have to thank my mentor when I was in residency, who was a big metabolic stone evaluation advocate, who every month would give us lectures on different scenarios and different patients that he would see in clinic and torture us in front of everyone and all the residents, all the attendings, and ask us to evaluate. But thank goodness for that, because I had become very good at doing my own metabolic evaluations. Of course, you also need the time and patience to do these evaluations, because when you see someone has low urine volume or high supersaturation of calcium oxalate and high calcium in their urine, you need to be able to correct that. Tell them to increase their volume, maybe decrease their sodium. The sodium is slightly elevated. Sodium and calcium will also decrease because they travel together. And you need to repeat this. So you need to have a clinic where you can follow these patients every 4 weeks or 6 weeks or every 3 months. If you're a high volume surgeon and only have 1 day or 1.5 days in clinic, you may want to find a partner or a nephrologist who specializes in metabolic stone evaluation. Most nephrologists, by the way, do not specialize in metabolic stone evaluation and are not experts. They are more interested in treating patients with dialysis than they are treating with patients with stones. So there's no consensus on getting 1 versus 2 collections. I typically get 2 collections in the first time, because many times someone will either not do an adequate collection in one of their 2 collections, or they will cheat and hydrate themselves for one of the collections, or sometimes one of the collections will be completely normal and the second collection will show an abnormality. Subsequently, I'll typically only get 1 collection once I've corrected their abnormalities. Multiple collections, again, can reveal additional diagnoses, and should also perform a quantitative screen for cysteine in patients that are at risk. This is just a table looking at the metabolic process behind cystinuria, metabolic processes behind uric acid, infection behind infection stones, and RTA, primary hyperparathyroidism, medullary sponge kidney, and carbonic anhydrase inhibitor therapy for predominance of hydroxyapatite stones. So in terms of medical management, patients are interested. It does work. And specific medical therapy is superior. Medical therapy is cost-effective, and diet therapy does work. So metabolic evaluation, who and how? Well, for patients with urine abnormality of low volume, the treatment is obviously to increase fluid. For hypercalciuria, it may be thiazide diuretic, if not just slightly lowering someone's sodium intake. For hyperuricemia and uric acid stones, allopurinol is a treatment, and for hypocitraturia, potassium citrate. In terms of follow-up, stone formers managed with diet and drug therapy should be monitored. Imaging studies should always be performed to identify stone growth or recurrence. Typically, ultrasounds can be performed, and if ultrasounds show or demonstrable growth, you can follow it up with a KUB or a non-contrast low-dose CT scan. 24-hour urine are always performed generally to monitor response to therapy, whether it's diet therapy or medication therapy. And the frequency of imaging and urine collection should be tailored to the aggressiveness of the disease, but generally within 6 months of therapy. So if you obtain metabolic evaluation with blood work and urine evaluations, and you prescribe either diet therapy or medication therapy, you should typically obtain another 24-hour urine collection or collections at about 3 months or 6 months. And if there's a correction of their abnormalities, you can follow them up in a year and yearly thereafter. If medications are prescribed, appropriate monitoring of blood tests is also required to assess for potential adverse effects. And wow, I actually made it with 8 minutes to spare. So I want to thank you all for joining. I know this was a little bit of a dry topic, but I hope you learned that oftentimes what we do in practice and when we see a patient in the emergency room or in our offices are not exactly in line with the AUA guidelines for surgical management of kidney stones. And I wish all of you best of luck on the in-service exam and going forward. Thank you very much.
Thank you so much, Dr. Munver. That was phenomenal. That was really outstanding talk and covered a lot of ground, reviewing some very high yield topics in stone disease. So I think on behalf of everyone, we really appreciate having you here. And I really learned a lot. I'm sure everyone else did too. Join us again, everyone, later this week. We have